Getting started. So, welcome everybody, and thank you for joining Amethyst at Penn's April seminar. We are proud to offer this content through our Amethyst at Penn Hub, which stands for Achieving Maternal Empowerment and Transforming Health through Implementation Science and Training. Funding for this hub comes from the NIH's Improve initiative, which aims to reduce maternal mortality, improve pregnancy, perinatal, and postpartum care, and to address the factors that have led to severe disparities in outcomes for marginalized groups. As a reminder, we will be recording this discussion and it will be available on our YouTube channel for review after the session. Please feel free to put any questions in the chat, and there will also be time for additional questions at the end. This month, we are fortunate enough to have Madeline Perry here to speak with us about financing maternity care in the US. And so I'll turn it over to you, Maddie.
Okay, great. Hopefully everyone can hear me. If not, I'm sure somebody will have let me know, hopefully by now. So I am so looking forward to talking to everyone today about financing maternity care in the US. I do want to give a huge thank you to Amethyst for inviting me to speak at the April Implementation Science and Maternal Health Seminar. So I am excited to share this presentation and hopefully use this presentation as a launching pad for further conversations and collaboration. We'll get started. So I have nothing to disclose, and I'm just going to give a little bit of background information about myself. So I think
Oh,
big picture is that structural determinants.
sorry, Maddie, you're muted.
Okay, there we go. I think I'm
Oh.
unmuted now.
Very good.
Okay, great. So a little bit about me. Structural determinants of health have really been a driving force in my career in medicine thus far. They've been a common thread through the work that I've been doing through medical school, residency, fellowship, and onwards. I did residency at the Integrated Northwestern and Cook County Health program in Chicago. And when I was in residency, a lot of the research that I focused on was focused on state level policies and characteristics and how they were associated with perinatal outcomes. After residency, I decided that I want additional training in health services research. And so I applied for and became part of the National Clinician Scholar program at Penn, which is a health policy research and advocacy fellowship. And this is really where I started to look into the finance side of maternity care. And I've done research on private financing of healthcare innovation through venture capital, have looked at innovative care delivery models, and continue to focus on state level policy, but largely through the lens of Medicaid policy. And so onwards, I've continued at Penn as a maternal fetal medicine fellow with really an interest in the intersection of high risk maternal health conditions and health policy. And so I think a logical next question for everyone who is on this meeting is why finance? And to state the obvious, money matters. And, early in training, when I was naive, eager, and just felt like if we all kind of put our heads together, we could solve a lot of problems. I would ask a lot of questions about why we weren't doing certain, like evidence-based practices. So at the residency that I was at, we weren't able to give everyone a blood pressure cuff. We weren't able to give all pregnant people blood pressure cuffs. And, I was like, why aren't we doing this? This makes a lot of sense. And the reason was that we didn't have a way to sustainably do that. There was no insurance coverage for that in Illinois at the time, and we didn't have grant funding that would allow us to do that for forever. And so I think it's important because there needs to be a pathway for things to be paid for. And that has really driven me to get more interested and more involved in the financing side of medicine. So payment policy has the potential to drive care delivery, drive equitable care delivery, and drive improvements in outcomes. And so understanding this financing of the maternity care system is really critical. This is going to be our roadmap for the presentation today. And so we're going to go over healthcare spending and payments in the US, insurance and cost of perinatal care, models in perinatal care, the global obstetric fee, alternative payment models, and then state level policy. And so to start off, we'll go ahead and we'll talk about healthcare spending and payments in the US. And I'm sure to this group, this will not come as a surprise, but healthcare and the cost of healthcare in the United States is very high. So in the US, we are spending about twice as much per person on healthcare in comparison to other wealthy countries. And you can look here at this graph right here. We have GDP right here in the x-axis, and we have the healthcare spending per capita on the right axis, and the United States is this green dot right here. And so we are spending a lot more per GDP than other countries. And in fact, we are actually spending 18% of our GDP is going to healthcare spending. So that means in the US, one in every $5 that is spent is going to healthcare, which is an astronomical amount. And this is very different than in the 1960s. So earlier on, healthcare spending in the US represented only 5% of the GDP. So importantly, it's important to say that healthcare spending in the US and having increased amounts of healthcare spending do not necessarily mean that there are improved outcomes. And the life expectancy in the US is actually 3 years lower than life expectancy in other countries in the OECD. And so if you look at this graph right here, we have these are countries that are in the OECD. This is their average life expectancy at birth. And then this line right here, this is the United States. So even though we're spending more, that doesn't necessarily mean that our outcomes are better. And I think this big picture is important because it really provides insight into recent payment policies in the US. And these are policies that are also shaping how maternity care is provided and reimbursed. And so payment policy in the last 10 to 20 years in the US has really focused on curbing spending and improving affordability. And probably the most notable example of this is the Affordable Care Act, or the Patient Protection and Affordable Care Act. This was signed into law in 2010 and then ultimately went into effect in 2014. And there were three main goals of the Affordable Care Act. The first was to expand insurance coverage, and that was done through Medicaid expansion, marketplace insurance, and then an individual insurance mandate, which was ultimately repealed. It was another goal was also to shift the focus of healthcare delivery from treatment to prevention. And then the third major goal was to reduce costs and improve efficiency. And notable contributions to payment policy from the Affordable Care Act include a focus on value-based payment initiatives, and then develop the Center for Medicare and Medicaid Innovation, or CMMI, as you'll oftentimes see it referred to. And the purpose of CMMI is to develop, test, and promote innovative care delivery models in the US. And so since the AMA, there's also been some increasing focus on hospital transparency, lowering prescription drug costs. But this has been the kind of the movement and the focus in financial policy in healthcare is really to try to curb spending as much as possible. And important to conversations about healthcare spending and payment is a review of the different types of payments in healthcare. And I think this is important to go over because if you listen to people in politics or you listen to folks talking about financial policy and healthcare or payment policy, you'll hear a lot of terms thrown around, and it's really helpful to understand what they mean and what they mean in healthcare. And so generally, when we think about different types of payments in healthcare, we think about fee-for-service, which is over here, and then we think about value-based payments, which are over here. And this graphic provides a really great framework for understanding these different types of payments. And this graphic comes from an organization called Healthcare Payment Learning and Action Network. And this is what's really commonly used in the literature to describe different types of healthcare payments. So fee-for-service is what we consider to be the traditional payment model in the US. And so healthcare services are paid for individually. So the total payment that somebody gets for providing healthcare is driven by the volume of services that they provide and the types of services that they provide. Over here on this side, we have value-based payments, which are sometimes referred to also as alternative payment models. And value-based payments are different in that they're incentivizing high-quality, cost-efficient care. These are payments that are oftentimes linked to quality and value. And in some situations, healthcare providers will actually assume a level of risk. And that means that if they don't meet certain metrics, they might actually have to pay a penalty or pay a fee back to an insurer. And in this framework that we have here, as you move from category 1 to category 4, you're going to have increasing amounts of financial risk for the people who are providing care and a shift towards what we consider population health management, which we'll talk about. So just briefly going through these different types of healthcare payments. The first, fee-for-service, like I mentioned before, you're billing separately for outpatient visits, labs, ultrasounds. And that is what we consider more traditional payments in the US healthcare system. Moving to the right on that framework that we have, the next type of payment is a fee for service, but linked to quality or value metrics. And an example of this is called pay for performance. So in this situation, you're still billing for all of your individual services, but you might get a bonus or a financial reward if you meet certain metrics, for example, for care coordination or reporting certain data. So there's very limited provider risk in this type of payment, but there is reward if you meet certain quality or cost metrics. Moving further to the right, further into the value-based payment category, you have this category 3, which is an alternative payment model that is built on a fee-for-service architecture. And so in this model, there's an opportunity for shared savings, which means that you might get a bonus, but there's also a risk that you face a financial penalty. And an example of this that some people might have heard about is episode-based payments that are used for joint replacement. And so in these situations, what happens is that a hospital is given a specific amount of money surrounding all of the care that might be provided for a joint replacement, including the surgery itself, the hospital stay, any sort of complications, medications, etc. So if this person has an uncomplicated course after their joint replacement surgery, there's a good chance that the hospital is going to be able to keep some of that extra money. And so they're going to have gain sharing, or they're going to get a little bit of a bonus. But if that individual has a number of complications and they're lost to follow-up and they're readmitted, then they might actually end up losing money on that service that they provided. So it's a single payment for an entire episode. And then the last kind of category to talk about in this value-based payment category is what we consider to be a population-based payment. And so in population-based payments, rather than paying for an individual service or an individual episode, providers and healthcare systems are getting paid a standard amount per member or per patient per month. And that's a phrase that you'll hear often is the PMPM, per member per month. And so an example of this is that many managed care organizations are contracting with Medicaid on this principle. And so they will get paid a per member per month fee for the people that they are taking care of, and they'll receive that money from Medicaid. And then with that money they receive, they're on the hook for all of the care that those people might require. And so when we are thinking about these different types of healthcare payments, the number of value-based payments, so payments in these three categories right here, has been increasing. And the percent of payments in these categories 3 and 4, which are oftentimes the ones that are specifically referred to as alternative payment models, have actually doubled over the about 10 past years. But when you are looking at which insurers are using value-based payments more often, we find that commercial insurers are using value-based payments the least often, and it's actually Medicare and Medicaid that are using them more often. So with this so that is important information that we'll kind of take moving forward, and we apply to some of the alternative payment models that we talk about moving on in this talk. I'm next going to talk about insurance and the cost of perinatal care. And I think this is important to bring up because insurance and insurers are the ones who are really paying for the majority of costs related to perinatal care in the United States. And in many situations, payment policy may work through insurance coverage to drive changes or improvements in perinatal care. So another statistic that is not going to be a surprise to a lot of the people on this call is that Medicaid pays for nearly half of all births in the United States. And in rural communities, that number is actually higher. And it's really important to focus on folks who are insured by Medicaid because these are people who disproportionately experience maternal morbidity. And the Affordable Care Act had Medicaid expansion built into it, and Medicaid expansion has really broadened access to Medicaid coverage in the pre-pregnancy period. But what's important is that for people who are not in states that have expanded Medicaid, there's oftentimes very limited options for them to have access to insurance coverage if they don't have insurance through their employer. And there are still 10 states that have not expanded Medicaid in the US. And so there's a lot of places where people do not have that Medicaid expansion or more liberal Medicaid coverage in a non-pregnant state. Medicaid is important because Medicaid programs really do work to strengthen maternal health care quality and outcomes, and they can do so through innovative care delivery models and alternative payment models, which we'll talk about in a little bit. Along with insurance, it's important to talk about insurance churn, and there's a significant amount of insurance churn in the United States. So insurance churn is the process of switching from one insurance to another insurance or switching from being insured to being uninsured. And 27% of birthing people who had Medicaid during pregnancy were actually uninsured in the pre-pregnancy period. And that's a really large number of people who aren't able to access preconception care or primary care. And rates of churn to being insured to uninsured during the perinatal period are higher in states that did not expand Medicaid. And so here we have churn, and then we have states that are not expansion and expansion, and you can see that the non-expansion states have higher rates of churn. Insurance churn is important because any disruption in care can increase the emergency department use, can lower medication adherence, and can worsen self-reported health. And then along with insurance churn and rates of uninsured in the pre-pregnancy period, still about 6% of birthing people are uninsured at the time of birth. Along with insurance churn and looking at an insured population, out-of-pocket costs for pregnancy care are increasing in the US for people who have insurance, specifically commercial insurance. So not only are the costs of healthcare increasing for our entire healthcare system, but also for birthing people who have commercial insurance. And what research has found is that mean out-of-pocket costs are increasing. This is largely driven by increasing deductibles, and deductibles are the amount of money that you have to pay out of pocket before your insurance starts to kick in. Research that was done in a commercially insured population found that medical debt was more likely among pregnant and postpartum people in comparison to people who are not pregnant. And they also found that there's a higher likelihood of medical debt in the lowest income neighborhoods. And so policies that reduce perinatal healthcare spending may help to mitigate financial hardship related to experiencing a pregnancy in the US. And many of the alternative payment models that we'll talk about in a little bit will actually try to do just that. So there are a number of ways that maternity care is reimbursed, and I'll summarize a couple of those mechanisms here. And I'm about to share a table that might look a little bit complex, and I think a caveat to this entire summary is that this is a simplification of a system that is very complex with a number of moving parts. But I think an important takeaway that I want everyone to have is that even in these complex reimbursement schemas, there are going to be some core identifiable components that you can use when thinking about implementation or research or health equity. And so I'm hoping to distill some of those core elements. And so before we dive into this chart, I'll just break it down a little bit. Here in this top row, you see the period of the perinatal care episode. And so we have prenatal and postpartum care, and then we have labor and delivery care. Below that, we have the type of provider or the hospital system that will be charging or getting reimbursed. And so we have maternity care providers, facilities that will charge a fee, and then other providers. And then on this left-hand side, in this column, you have the type of payment. And what I'm going to do is I'm going to talk about how each type of payment occurs in these two different time periods with different providers. So here, and this is going to be going back to that framework that we looked at, thinking about different types of payments. We have more traditional payments are in the top part of this table. Value-based payments are at the bottom part of the table. And so if we think about fee for service, a very traditional way to pay for healthcare, you're paying for all of the services provided in each visit in both the outpatient setting and during the labor and delivery episode. And so that would include charging separate fees for the maternity care provider, everything that's used during the hospital stay, and then different fees that are charged for different providers that might see that patient. And so every component of the care is charged separately. For the global fee, and we'll talk about the global obstetric fee a little bit more, this is a type of payment where there is one amount that is paid for all routine prenatal, postpartum, and labor and delivery care. And the global fee largely is providing to the maternity care provider. It doesn't actually cover the facility fee or the fees of other people who might provide care to the patient during the pregnancy episode. And so instead, you have, for example, per diem rates. And so that could be a rate that the patient is charged for every day that they're hospitalized during the labor and delivery episode. And you also have something called diagnostic related groups or DRG payments. And so that is going to be the payment that is going to the hospital itself. That's the facility fee. And for labor and delivery, there are different DRGs for different types of delivery with varying levels of complexity. So you can have basically low, medium, and high complexity for vaginal deliveries and for C-sections. And those are all going to be different fees. When we move into the more value-based payments, you have pay-for-performance schemas, and that's when, like we talked about before, incentives are tied, or incentives are paid to either hospital systems or providers for achieving goals on specific quality or cost metrics. You have episodes of care where an organization might receive a single payment for all of the maternity services that are going to be provided during a single maternity episode. And then you can have capitation, and that is that per member per month fee. And so perhaps for all of the pregnant people that might be covered by an insurer, they're given a specific amount of money per month to cover all of the care that that pregnant person might be using. And how these forms of reimbursement can be used can be overlapping. And so, for example, you can have an episodes of care model where in which might actually start with a fee for service. So providers might initially bill fee for service, and then retrospectively on the back end, payments might be adjusted based on episode cost and quality metrics. Similarly, you could have a global fee reimbursement that is tied to quality metrics and therefore could fit into the pay to performance category. And so there's not a one size fits all for how all maternity care is reimbursed. And the other thing that's really important to note is that reimbursement can actually be different because there are negotiated agreements between hospitals, providers, and insurers. So even if you look at two different institutions that are getting paid from a global fee, what that monetary amount might be different based off of negotiated rates that that hospital might have with specific insurers. And so next we'll talk about the global fee that I mentioned, and this is a unique aspect of payment for maternity care. So the global obstetric fee is a one-time billing that includes all professional services for routine antepartum delivery services and postpartum care. And like I previously mentioned, the actual monetary value is actually negotiated between providers and insurance companies. That being said, the average reimbursement by Medicaid is lower than that of commercial insurers. It's about 30% lower than what commercial insurers will pay for the global obstetric fee. In the most recent survey that ACOG sent out, about 58% of OB providers report that they're getting paid through the global obstetric fee. But when you ask them about their perceived reimbursement rates or how much they get from that global obstetric fee, about half of them will actually say that they perceive the global obstetric fee to be less than what they would get through a fee-for-service arrangement that they might have with another insurer. And then importantly, 37 of 50 state Medicaid programs, the majority of state Medicaid programs, are using the global obstetric fee. And over the past couple of years, there have been some concerns related with the global obstetric fee. And part of that is because the CPT codes or the current procedural terminology codes that people will use to bill, those actually haven't changed for about 30 years. And so, of course, how we're providing maternity care, pregnancy care, and the level of complexity of pregnancy care has changed over the past 30 years. And it is felt that the global obstetric fee doesn't currently align with ACOG's recommendation for tailored prenatal care. And tailored prenatal care, which I'm sure many people here are familiar with, recommends that there is an early pregnancy comprehensive risk assessment and customized visit schedules and services based on a patient's medical and social risks. And so a number of services that would be included in tailored prenatal care wouldn't necessarily be billed for or reimbursed with this global obstetric fee. So this here is a box that demonstrates services that are not really captured by the global obstetric fee, but are already being provided by pregnancy care providers. And so this was really one of the bigger impetuses to make a change to that global obstetric fee. And there was a lot of advocacy leading up to this, but there actually is going to be a huge change in the global obstetric fee, and that it's actually going to be retired. And there's going to be a transition from the global obstetric fee back to fee for service for payment for pregnancy care in the US. the CPT codes for the global obstetric fee will actually be completely deleted and there will be new codes to replace them. And this is something that is going to be going into place January of 2027. And so it is an upcoming really big change in how pregnancy care is going to be reimbursed in the US. This new fee system is something that is really actively being developed and revised at this time. And the AMA, in collaboration with ACOG, is working on these codes. And they actually released a webinar earlier in March with an overview of these changes and with a summary of where they think some of the future CPT codes actually might go. They say that they're going to continue to release updates, trainings, et cetera. For anyone who might be interested in watching that webinar, it is very easy to Google. It's also something that is completely free, but I have a QR code here I'm happy to share afterwards. I felt that it was a pretty informative webinar about how that transition from the global obstetric fee to fee for service is going to look like. And I think what's important to think about moving forward in a world, after the global obstetric fee is that this will be an area that's really important for future research. And it will be important to understand how practice patterns, cost of care, and outcomes may change. And I also think it will be important to understand how hospital systems, how providers with differing level of resources, how they're actually able to implement these changes and how they're able to successfully bill, because billing takes a lot of resources and a lot of work. And so these are all things that really remain to be seen and will be important to follow as these changes go into effect in 2027. And the next area that we'll talk about within payment policy is alternative payment models in obstetrics. CMMI, the Center for Medicare and Medicaid Innovation, has the goal of having the majority of Medicaid beneficiaries covered by alternative payment models by 2030. And so this is something that is already happening in obstetrics and likely will continue to be a dominant feature of payment models in obstetrics. So within obstetrics, when thinking about alternative payment models, the majority of them are really concentrated in Medicaid programs. There are some that exist in commercial payers, but really the majority of them are happening within Medicaid programs. And there are three dominant models of alternative payment models that you see in obstetrics. They include episodes of care, paying for performance, and the pregnancy medical home. And we've kind of touched on these a little bit already, but just to review briefly what these would look like in pregnancy is that for the episodes of care model, bundled payments would be used to manage the quality and cost during an entire perinatal episode, so a single fee for an entire perinatal episode. For pay for performance, there would be financial incentives to meet certain quality or maybe cost metrics. There could theoretically be penalties if metrics are not met. And then for a pregnancy medical home, this is similar to the primary care medical home. And so that's where you have single institution that is going to be like on the hook for addressing all of the clinical, behavioral, and social aspects of care. And these are some of the examples of quality metrics or services that might be included in alternative payment models to incrementally improve outcomes. And so you can see there, it can be a focus on substance use disorder, social determinants of health or structural determinants of health, perinatal mood and anxiety disorders, dyadic care, postpartum care. And some of the things that alternative payment models might require as a quality metric might be things like required screening for substance use disorder or having staff experienced in substance use disorder, opioid use disorder. From the perspective of PMAD, there might be required screenings or there might be a requirement that there's facilitated connection to treatment. When it comes to social determinants of health, you'll see many of the alternative payment models, especially accountable care organizations, are requiring SDOH screening. Some of them have a health equity score or require that staff are trained in SDOH. And then when we think about dyadic care, which is focusing on the birthing person and the neonate together, there are some models that might also include neonatal metrics along with maternal health outcomes or outcomes for the birthing person to have a more comprehensive view of quality. And we'll talk through two examples of what an alternative payment model can look like in a state. And the first model that we'll talk about is the Tennessee perinatal episodes of care model. So in this model, Tennessee only included low and moderate risk birthing people, which we'll kind of talk about why that matters in a little bit. And the services that they had included in this episodes of care model were basically all prenatal delivery and postpartum care. So an organization was on the hook for that entire pregnancy episode. The quality metrics that they used is they only had three quality metrics. It was HIV screening, GBS screening, and then having a C-section rate that was less than 42%. And after a pregnancy episode, there would be a retrospective or an after the fact review of those cost and metrics. And if you met both the quality metrics and you met a pre-specified cost metric, so as long as your costs were below a certain threshold, you would get a bonus, and that bonus is called gain sharing. But if your cost of care for a patient was above the pre-specified cost threshold, you actually had to make a payment back to Medicaid, and that's called a risk-sharing payment. When Tennessee evaluated their perinatal episodes of care model, what they found is that this model actually reduced the amount that their perinatal episode cost by about 3.4% in a single calendar year. They also found that they had decreasing rates of C-sections and improved rates of screening for GBS and for HIV. So that model demonstrated how this perinatal episodes of care model and alternative payment model can improve both quality and cost metrics, at least marginally. The next example that we'll talk about is Connecticut's maternity pay for performance model. And so this was a model that was a little bit different. It was an optional model for any Medicaid provider to participate in. There was no limit on the risk level for birthing people. So you could have a low risk birthing person, a high risk birthing person who might be seeing a maternal fetal medicine specialist. And in this model, there's only bonus payments that were given out. And so there was no risk or no risk of having to pay a fee if certain quality or cost metrics weren't made. And the bonus payment was based on the total number of quality points that a provider was able to basically identify or kind of collect when caring for a single patient. And so you can see the measures that they were looking at right here. You have points here. And so they would total up the total number of points based off of these measures for a single birthing person, and they would get a bonus related to that total number of points. In this type of alternative payment model, there's no assessment of the cost of the episode. And so cost wasn't really built into it. So there were no risk sharing payments if certain metrics weren't met. When they did an evaluation of this model, there wasn't a formal evaluation of the cost that was done by Connecticut, but what they found is that their quality outcomes were overall mixed. And so while there was an increase in full-term vaginal delivery rates, there's actually a decrease in the people who are getting expedited early prenatal care, and their postpartum visit rate was about equivalent. And so this just goes to show, these two cases I'm sharing is I want to convey that outcomes within alternative payment models have genuinely been mixed. I think it would be great to say that all of these APMs have beautiful, amazing results and are markedly improving outcomes, but they really have been mixed. And I think that's important to think about. So something that I think is exciting about alternative payment models is their ability to promote innovation. And so certain types of alternative payment models have been associated, for example, with increased social needs screening, which right now I know, at least in a lot of the institutions that I've worked in, feels like something that we've almost done for forever. But it's really something that we didn't do like 5-ish years ago. And it was new at one point. And alternative payment models and accountable care organizations were kind of on the cutting edge of doing that. With payment that is linked to quality metrics, organizations are oftentimes encouraged to figure out how they can make these metrics work into their practice. And this sometimes can lead to innovative workflows, or maybe training up people to do a different skill. And so they really can be opportunities to promote innovation in a healthcare system. It's important to also say that alternative payment models can also be used to nudge the uptake of a new evidence-based practice or a practice with the ability to improve outcomes. So, for example, maybe an organization wants OB practices to have a health equity dashboard included in the care that they provide. And so if that is required by an alternative payment model, that's something that could facilitate the implementation of that new intervention. And so that link between APMs and innovation exists. And I think it is really interesting and exciting to think about. And then on the topic of innovation, venture capital, which is a form of private financing, oftentimes used to support startups, has actually entered into this value-based payment arena. And there are some startups that are backed by venture capital that are leveraging value-based payments. And their general value proposition is that they will say to organizations, we will help you to reduce the cost and increase your quality. Two examples of organizations that are doing this that have some name brand, I feel like, currently in the arena are Pomelo Care and Maven. These are both organizations that are providing virtual and hybrid wraparound care. And so they'll also provide some prenatal care, but they're oftentimes providing that in-between care. So in between standard prenatal visits with a primary OBGYN or CNM. The way that these companies work is that they contract with payers, whether they be insurers or employers, and they will negotiate a capitated payment. And so that is that per member per month payment. And the intention is that the services that they're going to provide are going to improve outcomes to the point where the cost for that birthing person is going to be less. And so I bring this up that value-based payment and alternative payment models are not just necessarily limited to what we think about as some of the traditional providers of perinatal care, and that they're also extending into venture capital, into some of these alternative ways of providing perinatal care to folks. So when we think about alternative payment models, I think the big question is, are there meaningful results? And I think that if you looked at a number of alternative payment models and looked at outcomes, you definitely can see that there are some small changes in quality measures and costs, but there isn't necessarily a huge impact on maternal morbidity, health inequities, or when we think about mistreatment or mistrust in the healthcare system. If we take a step back and think about some of the quality metrics that we are looking at in these value-based payment systems or alternative payment models, some of the quality metrics folks have argued falls short to some extent. And so, yes, while GBS screening rates are very important and are definitely necessary, that doesn't necessarily touch on the importance of community-based healthcare and multidisciplinary care. Another kind of issue that people identify with some of the alternative payment models is that there is a heavy focus on the provider and not necessarily as much focus on the community. And community-focused, community-based care can be the care that actually can end up connecting folks to people like doulas or community stakeholders that might be able to help with housing instability or other social drivers of healthcare. Alternative payment models also don't have the best ability to focus on the interpregnancy period, especially when you think about a perinatal episode of care. It might just focus on that perinatal episode and not necessarily on that interpregnancy period. And then finally, a number of these alternative payment models will exclude people who have high-risk pregnancies. That's largely because higher-risk pregnancies are thought to be higher cost. And so in order to protect people who are taking on financial risk, they say, we're going to not include people who are going to have the highest cost pregnancy. The caveat to that, though, the issue is that some people who have higher risk pregnancies are also the people who are likely going to benefit from some of these alternative payment models that really focus on coordination of care. And so I think to sum up everything related to alternative payment models that I've just talked about, alternative payment models will continue to happen. And I think there's an opportunity to really think about how we can continue to be thoughtful in how we maximize quality and improve costs in these models. And the next, I'll move from alternative payment models into state level policy and state level payment policy. And when I'm talking about this policy, I'm talking really about like what we call capital P health policy. So that's policy that's coming from laws or governments. And capital P policy is really important in determining what healthcare gets covered and how it gets covered. And I think many of us recognize how federal policy right now is a little bit of a chaotic arena and can be disheartening. But state level policy, you still really have a huge impact to affect healthcare outcomes and how people have access to healthcare. And these state level policies can be used to drive innovation and also to facilitate implementation of evidence-based practices. And so the next couple of slides will review the importance and some important concepts of state level payment policy. And I'll use a couple of examples to demonstrate that. The first is that insurance coverage can drive utilization. And the example that I'm going to use is Medicaid coverage of dental services. So, coverage of dental services is not actually required by Medicaid, which is something that I feel like is not talked about a ton. And it's not even required by Medicaid during pregnancy either. So, periodontal disease we know is associated with adverse perinatal outcomes. And in research that we did, what we found is that in a Medicaid insured population, teeth cleaning was much less likely during pregnancy in states where there was no Medicaid coverage or very limited Medicaid coverage for dental services. Whereas in states where there was robust coverage for dental services provided by Medicaid, teeth cleaning was much more common among those people who lived in the states who had Medicaid. And so this is just one of many examples of how insurance coverage and Medicaid coverage, which can be developed through policy, can help to drive care utilization. The next aspect of policy that I want to talk about is how payment policy can help to mitigate health disparities. And the example that I'm going to use for this is telehealth. I'm sure many of us are familiar with, there's been a huge expansion of telehealth in the post-COVID world. But now that the pandemic is over, the public health emergency telehealth policies that were in place during the COVID pandemic have expired. And what that means is that state telehealth policies now differ quite drastically on a state-by-state basis. And so not all states, for example, require insurers to pay the same amount for a telehealth visit as they would for in-person care. Similarly, not all states reimburse remote patient monitoring, like remote blood pressure monitoring. And so telehealth has that potential to improve access to obstetric care, but how it's paid for can influence the uptake of it. And there is evidence that telehealth can help to decrease disparities. So in a study that was done here at Penn, telehealth implementation was associated with decreased racial disparities in postpartum visit attendance. Similarly, Heart Safe Motherhood, which is a remote blood pressure monitoring and texting program, also demonstrated reduced racial disparities in blood pressure and blood pressure follow-up postpartum. And so it's important to focus on telehealth policy because it has the potential to increase access to care and decrease disparities. But importantly, it needs to be paid for. And so if you think about many remote blood pressure monitoring programs in the US, many of them have actually started with NIH funding or other grants, and transitioning to insurance reimbursement can be a really powerful pathway to sustainable implementation of these interventions and similar interventions. But not all states provide reimbursement for blood pressure monitoring at this time. And then the last example of important state level policy is postpartum Medicaid extension. And this is something that really has had a huge impact on how care is paid for. As many people probably remember, before this policy, the majority of people who had Medicaid had their Medicaid ended at 2 months postpartum. And so at 2 months, they oftentimes completely lost insurance because many people did not have the option for commercial insurance. And so that meant that the cardiology appointment or the primary care appointment or the other specialist appointment that you wanted somebody to have at 3 or 5 months postpartum wasn't possible. But now in nearly all states, except for Arkansas, there's extended 12 months of Medicaid postpartum. And that I think is really incredible in terms of accessing care postpartum. This policy, and this is something that has happened recently in the past 5 years, and it has already been associated with increased use of contraceptive care, primary care, mental health. And even though nearly all states have postpartum Medicaid extension, this is something that was passed on a state by state basis. And so just another example of how state policy is so important. And to wrap everything up, the last couple of slides are going to be focusing on how we can incorporate a payment lens into research. And I know that this group has a focus on implementation science in research. And I really think that understanding financial structures and payment policy is critical for long-term implementation of interventions. And I have over here on the left-hand side a couple of questions that we'll talk through just to get you thinking about how payment policy might impact your intervention. But on the right side, I have a couple of great resources that I've used a lot in the past. This first one is NASHP State Tracker. So NASHP is the National Association of State Health Policy. And what they do is they'll track certain health policies on a state-by-state basis. So if you're interested, if in your state a policy related to some sort of intervention might be different than another state, they have a lot of examples where they're comparing the same health policy on a state-by-state basis. Another great resource when you're thinking about payment policy is this report from Kaiser Family Foundation. And this report looks at Medicaid coverage of pregnancy-related services on a state-by-state basis. So it compares what different Medicaid programs are covering within a perinatal episode. And these will stay on the slide for a couple minutes, so no kind of rush to get the QR codes. And again, I'm happy to send out any links after the fact as well. So when you're starting to think about how payment policy might impact the intervention or the innovation that you're thinking about, some questions to think about. This first one is long-term, how will this intervention or innovation be paid for? Will it be paid for through insurance, through clinic funds, through the hospital, through grants? And that's important to think about upfront so that you know that moving forward and you think, if you don't identify a way for your intervention or the thing to be paid for, that's something that is important to think about and think if there's a workaround for it or how could your intervention be sustainably paid for? Another important question is asking, is insurance coverage or reimbursement different by insurer? So is it covered by Medicaid but not commercial insurers? Because that might mean that commercially insured birthing people might have a higher barrier to using that intervention or receiving that intervention. Could this innovation be included in an alternative payment model? So could this be a quality metric? Does this intervention drive high value, cost efficient care? And how is value-based care being used in your hospital system or in your state or in your city? And how might this be incorporated? Could a policy change help to expand access to the intervention and innovation? So is the thing that you're studying not currently reimbursed by insurance, but should it be? Could this be actually an opportunity for advocacy to advocate for increased coverage, either by Medicaid or by commercial insurers? And then what is the return on investment? So, does this intervention, even if it isn't covered by insurance, does it actually save time? Does it allow people who were doing one task to actually work on a different task? Does it save money? Does it save other resources? And could that actually be an argument for how you could have more sustainable implementation of the intervention into practice patterns? And so these are just a couple of questions to get you thinking about how payment policy might impact or be related to the work that you're doing. And as everyone in this seminar is familiar with, health policy and innovation doesn't just stop with the intervention. Implementation is really critical to ensuring that people gain access or benefit from the thing. And it's important to study implementation of payment policy and how payment policy can actually impact implementation. And so, along with standard frameworks that you can use for implementation science like CIFR, PRISM, REAIM, there are policy-specific frameworks to guide research on these questions of how can we study the implementation of a policy and how might a payment policy impact implementation of something else. And I do want to give a shout out to Dr. Ham for introducing me to this article, but this is a great article here. And in this article, they've developed two frameworks to understand how implementation and policy interact. And the first framework that they describe is a framework studying the framework that helps to study the implementation of a policy. And so how do you study the implementation of a health policy, which is something that has a number of different moving parts? The second framework they develop is a framework that provides steps for evaluating policy-related influences on implementation outcomes. And so this is a really helpful paper if you're thinking about what is a framework that I can use to use implementation science and study health policy. And another plug when we're thinking about looking at payment policy, the impacts of these outcomes, along with studying implementation, it is really important to look at outcomes related to health policies, especially with changes to payment policy. And a really useful methodology to do this is something called quasi-experimental methods of causal inference. And these are methods that I think are really exciting to use, and they have the ability to infer causality from observational data. And so a couple of names of methods that are included in quasi-experimentals are things like difference in difference, regression discontinuity, instrument variables. This is like a whole separate talk. That is also, I think, very exciting and very applicable to looking at policy. And what quasi-experimental methods do is they'll oftentimes try to leverage natural experiments. So, for example, if you have a policy change in one state but not another state, how can you use that as a natural experiment to compare and understand the outcomes of the policy in that one state where it changed? And then to tie this all together, I just wanted to provide an example of how a novel care delivery model can have an implementation gap. And so, an example related to some of the work that I'm currently doing is I am looking at Medicaid covered doula services. And this is a policy that is currently passed and is actively being reimbursed for by Medicaid in 26 states. So, in 26 states, they have a policy to provide Medicaid covered doula services, and they're already paying doulas for providing care to people who have Medicaid. In research that I've done that's been supported by other literature as well, we know that states that have adopted this policy, especially earlier adopters, in those states, less than 1% of eligible birthing people are actually using these services. So there's a huge gap between the passage of the policy, Medicaid covered doula services, and people using those services. And then you have to think about if so few people are using the services, how could we, then you have to think about the outcomes after that. There's so few people who might benefit from those outcomes then. So the study that I'm doing right now to try to bridge that gap is actually using qualitative research with an implementation science lens. And I'm talking with Medicaid and public health officials about the implementation of Medicaid covered doula services. And this is just one of many examples how innovation and innovative care delivery models, innovative models that provide payment for additional services, don't just stop with the development of the policy or the intervention, and they really have to continue through to implementation. And then this is the last slide before the summary. I want to end on a positive and optimistic and a can-do note. And I think in the process of doing research on implementation and thinking about payment policy, you might actually come to the conclusion that certain policies, either at the hospital, city, state, or federal level, need to change. And so I want to introduce this idea of the policy window. So a policy window is when there's a brief opportunity to enact change, and that is when the problem, the proposed solution, and the political momentum all converge. And this is considered a policy window because it is open for only a brief period of time. An example of this is during the COVID pandemic, there was a ton of telehealth reform. And that's because the problem, the solution, and the political momentum were all aligned that we need easier and better telehealth coverage. But nowadays, if you try to pass telehealth coverage policy, you still can, but it's just not as fast as when it was happening during the COVID pandemic. And so, as physicians, care providers, researchers, we are deeply embedded in both the problem and the potential solution. And I think that we are in a really important position to advocate for policy changes. And I know that the political landscape at times might look bleak, but there are a number of local and state legislatures that are still very interested in passing health policy related to perinatal care, even in red and purple states. And so, just a couple of take-home messages to summarize. Financing of maternity care is complex, but there are common building blocks that you can identify in complex models. The cost of medical care and payment models and payment policy are a dominant topic in healthcare and in politics. And so having a baseline understanding can be really helpful, especially if you want to get further involved in political advocacy. Reimbursement for the obstetric services is going to change in 2027, and the global fee is going to be retired. There will be a lot of research that hopefully will come out of that in the future. Next big takeaway, alternative payment models have the opportunity to reduce costs, improve quality and outcomes for reproductive healthcare, and are probably here to stay for a while. And then healthcare policy and payment policy and reimbursement can drive changes in access and quality to care. And then, especially for this group connected through Amethyst, research on types of payment models, payment policy, and are so critical. And research doesn't just stop with the policy, but really needs to continue on to implementation and to outcomes. And with that, I want to give a big thank you. Thank you to Amethyst Implementation Science and Maternal Health Seminar. I have had just the wonderful benefit of having some incredible mentors that I've continued to work with and have just worked with a really number of great collaborators and colleagues through this process. And at this time, I am happy to take questions, ideas, collaboration. I have my email up here as well if there's anything else that you would ever want to talk about or work on together. And I see that there's a couple things at the chat. Um, and I think we have a couple pre seminar questions too that came up. But if anyone
Yeah.
has questions that they want to say out loud, I can also address those.
Yeah. Thank you so much, Maddie. That was great. If anyone wants to unmute or drop anything in the chat, feel free. Um, looking, see if there's any hands. One of the questions that came through in the registration, we'll probably have time to touch on maybe this one, are what are key metrics that you collect in your work to drive this work forward?
Yeah, I think that is a great question. I think a lot of that kind of depends on the research question that folks have. And so I think of like three main questions when thinking about key metrics that you might want to collect. And I think the first one is, it depends on what intervention you're studying at what level, but are people using the intervention, for example, the payment policy, and what is the uptake of it? The next question that I think about is, does this intervention, does this policy work? Does it achieve the outcomes that you want? And so you can think about looking at perinatal outcomes or quality outcomes. And then the last key metric that I think is important in thinking about is cost. And that's something that sometimes can be a little bit more challenging to look at. There are certain data sources where you can look at cost, but looking at, what is the cost before and after a policy? Are we paying more or less? And who is paying more or less? Is it the hospital system? Is it the patient? And so those are a couple of questions that I use to really start to think about what are the metrics that are going to drive your specific research question.
Great. Well, we have about 2 minutes left if anyone else wants to ask anything or comment anything, but that was amazing. And it will be posted to our